I'm Brian Rini. I'm a GU medical oncologist. I'm chief of clinical trials and a professor of medicine at the Vanderbilt Ingham Cancer Center in Nashville, Tennessee. So at ASCO 2023, we presented data, 5-year follow-up data from the KEYNOTE-426 study, which was a large randomized trial of axitinib plus pembrolizumab compared to sunitinib in frontline clear cell kidney cancer, very similar to other trials conducted that have led to immune-based doublets being the standard of care in this disease. These data were initially presented now a few years ago, have been presented and published from 2 other analyses. So this was the 4th update of these data. And I think it was important because it was a 5-year minimum follow-up. So we're starting to get long-term follow-up from these IO-TKI data sets. Important when you're counseling patients in clinic and you're treating these patients to sort of know the history of what happens to patients who are treated with this regimen over time. I think what was the take-home points, at least for me in this data set compared to previous data sets, was, I think, a reinforcement of the objective response, complete response, and progression-free survival benefits that we're seeing. This is not surprising since most of these events occur early on. There was maintenance of an overall survival benefit. It wasn't statistically compared, given that statistical significance had been met early on. This hazard ratio was 0.84, higher than previous, I think, reflecting that patients who are still on study are receiving multiple lines of active therapy. So the sunitinib control arm received PD-1 inhibitors predominantly and also multiple lines of VEGF inhibitors, all of which can extend survival. So I don't think it's surprising we're seeing a slight increase in the overall survival hazard ratio. And then I think what was new in this data set was a completer analysis. So about 28% of patients randomized to axi-pembro completed 2 years of therapy. And this analysis looked at what happened to those patients. And 70% of those patients were alive at the minimum 5-year follow-up mark. And over a third of those patients were progression-free. So not surprisingly, those patients do quite well. But again, I think the data are useful and the numbers are useful when you're counseling patients in clinic who are approaching that 2-year mark where pembrolizumab is stopped. I know many patients now getting to that mark who are starting to ask, what happens, what's going to happen to me? Should I continue? Should I not? And so I think that particular analysis was helpful clinically. Yeah, so a lot of questions in there. Cosmic 313 is fairly easy to deal with. That was a very toxic regimen. It showed some marginal PFS advantage, but no OS or other advantages. So that triplet regimen or any triplet regimen is not a standard of care in kidney cancer and generally not being used, nor should be used, in my opinion, until further data come out. In terms of 426, or really any of the other trials, and there was a clear 4-year update at ASCO as well, we don't have good data on how to select patients for one regimen versus the other. Ipi-Nivo's a very potent regimen with good durability, and I personally select patients for that based on presence of sarcomatoid features, which appear to be associated with particular activity of that regimen. Not just that regimen, but I think particularly in that one. But there's a lot of debate and discussion in the field about how to choose, and frankly, I think the consensus is that they're all good regimens. And there might be certain patients where you'd choose one and certain patients where you'd choose another based on comorbidities, blood pressure control, presence of autoimmune disease, which might make you choose against an all-immune regimen like Ipi-Nivo. So I think a lot of subtleties, bias in interpreting the data, familiarity with the regimen, especially the TKI component and how to dose and when to stop and when to hold drug. Many of us are trying to develop biologic biomarkers based on tumor or blood characteristics to truly select individual therapy for individual patients, but those trials are ongoing. And as it stands at present, none of the analyses have really truly discovered a biomarker to select patients. My last comment is that people often use IMDC criteria, which is our prognostic criteria in kidney cancer, but it is not a predictive criteria. It was never meant to be. And I think does a poor job of predicting response to therapy. and I don't think should be used in a predictive sense, although that's sort of how it's playing out. And I think as a field, we need to get away from restricting trials to certain IMDC risk categories. I think we're doing ourselves a disservice. So long answer, but short summary is no, we do not have validated clinical biomarkers in the clinic for selecting regimens in advanced RCC. So as you would imagine, with 5 years follow-up, the vast majority of patients are off treatment. We presented data on subsequent therapy received by each arm. And as we've known for kidney cancer, we have many active drugs, and so patients can and should get subsequent therapy, and they did so in this trial. The vast majority of discontinued patients received subsequent therapy. The sunitinib arm, 80% received a PD-1 inhibitor, presumably nivolumab, and both arms received multiple lines of VEGF inhibitors, more so in the sunitinib arm. Again, not surprisingly, because those patients came off earlier, so would have had a greater chance to receive subsequent therapy just in time. So I think these data reflect what happens in the real world. When I have patients progress on front line, I give them second line and hopefully third, fourth, and fifth line. So I think, it's good to see follow-up data in a large clinical trial, which is clearly a selected population at selected centers that represents what happens in the real world. Not entirely, of course, but at least as a reflection that it wasn't just one treatment the sunitinib arm got. It was multiple lines of treatment. And I think we see that reflected in the clinical data.